Welcome everybody to today's webinar, Introducing New Spine Technology in Any Setting of Care, Support from the Medical Science Liaison. I am Mary Rick Torres, Assistant Editor of the Becker's Spine Review and Becker's ASC Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We're really looking forward to hearing all of your questions. Also, in a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. Our presenters today are Dr. Hale Matthews, Chief Medical Officer of Paradigm Spine, and Devin Billiter, Medical Science Liaison of Paradigm Spine Midwest Central U.S. Division. And Dr. Matthews, I'll now turn the floor over to you to begin today's presentation.
Good day, everyone. I'm Hal Matthews, Chief Medical Officer of Paradigm Spine and a spine surgeon by training. I'd like to thank Becker's for the opportunity to present this information and Paradigm Spine for the opportunity of understanding the medical science liaison role. I think we have representation from at least 3 time zones, so this is an exciting time to get this information out to everyone. And I want to thank Paradigm Spine specifically for the wisdom to dedicate itself to better patient outcomes and the evidence to prove that, and also for keeping the medical in the medical device company. And I think that will show through this presentation today. So as we look at this presentation today, we're going to introduce the medical science liaison to the medical device industry. As many know, this is a pharmaceutical model, but we all know as clinicians that this has a role in medical device understanding and evidence and insight management. And we also want to see how this integrates with coflex interlaminar stabilization in that clinical message that's so proven with the evidence-based medicine model. And we also want to introduce some of the CMS rule changes for 2017, which will definitely affect the site of service for coflex interlaminar stabilization. So with this introduction, I'd like to turn the floor over to Devin.
Great. I so appreciate you kicking us off, Dr. Matthews. Hello out there, everybody. We can start with what I refer to as the sort of textbook definition of a medical science liaison. A few words that are key in this definition include clinically focused, helps all stakeholders, new spine technology, disease management, patient selection, and advocacy. But the best part is that all of these terms now apply to any setting of care, which we'll be covering in more detail later in the presentation. Next slide, please. How is a sales role different than an MSL role or a medical science liaison role? Well, I'm just throwing this out there because my boss is on this conference call with me. Salespeople do make commission. Maybe that doesn't have to be a difference, Dr. Matthews. What do you think?
Well, that's a good starting point.
I'll put that one on my Christmas wish list and we'll kind of leave it at that. In all fairness, sales personnel are focused on, you guessed it, selling. They may utilize marketing materials, surgical demo kits, etc., certainly to educate on appropriate use of the product, but also ultimately to close the sale. Sales personnel aim to increase volume with current surgeon users, create new users, and ultimately book more cases to meet sales quotas. Medical science liaisons have different end goals of collaboration, teaching, and advocacy. These may be with the surgeon, but it's also with the total healthcare staff, most often at more than one site of service that's tied to both that surgeon and that particular patient. The information provided that we provide is based upon clinical research, peer-reviewed articles, medical societal publications, and so forth. But it's really not boring. We make it fun. Next slide, please. As you can see, MSLs work with multiple stakeholders, including, but not limited to, the surgeon in their office. We function within all settings truly that are related to patient care. So a few examples of partnership and activity with other healthcare entities could include some of these. Maybe in services, in the hospital, or in an ambulatory surgery center, which would educate surgical staff. Perhaps we'll engage in educational programs with mid-level practitioners like PAs or NPs, or even with a referring physician group in order to connect them with our surgeon users. We might have meetings with executive level personnel at hospitals or at ASCs perhaps even to assist with cost-benefit analysis of coflex for the patients that they currently serve. We may have engagement with thought leaders or research coordinators at academic institutions, perhaps to initiate potential coflex study involvement. We also connect offices and patients to our reimbursement and advocacy partner groups in the effort to assist with private payer coverage. Truly, the list goes on and on. Next slide, please. As Dr. Matthews stated, the MSL role is fairly new to the device world, but we are an important resource in helping bridge the gap to new technology. We really operate based on a proof platform of evidence-based medicine. We work and educate all personnel in the office and the facility, including the front office, such as reception and scheduling, the middle office, which is usually the surgeon and the clinical staff, but also the back office in billing, coding, and even practice management. This education comes in a great number of forms: disease awareness, patient identification based upon symptomology and/or image guidance when appropriate, and certainly reimbursement education for surgeons and their billing staff to communicate properly to relevant payers. We really assist in linking the right patients to coflex from start to finish. Next slide, please. I promise that we talk about what MSLs do and how we can help you. This is very colorful, but these are our main areas of focus. Next slide, please. So much of the data in the spine world is tied up to 510K products, but Paradigm and the MSL team are truly dedicated to clinical research, as is evidenced by our level 1 data for coflex. This dedication to research includes both current and ongoing FDA-required studies for coflex, but it certainly does extend to additional community use studies with surgeons and beyond that. The MSL team is able to discuss the true evolution of spine treatment, sharing the story via key publications that might be from the past, present, even the future. We have binders filled up with articles. However, we do strive to employ our resources only as needed. Next slide, please. MSLs have to continue to learn in order for us to continue to teach. Makes sense. We have a common desire to be the most well-informed resources in our respective fields. Thus, we do continually challenge ourselves to stay current. We have a lot of strategies, and some of those include team journal clubs. This might be in the form of conference calls, etc. We do MRI webinars to increase our knowledge around that front. We may attend societal conferences. And of course, subscribing to, I had to say it, the weekly Becker's newsletters. We do love those. Those help us stay current. Next slide, please. Now, teaching, this is kind of the MSL team's jam. Our day-to-day job responsibilities include educational activities of all types, including, but certainly not limited to, educating the surgeon and, of course, the healthcare staff on what the coflex patient could possibly look like. We may assist customers with payer education, from initial dictation all the way through the appeals process. We may use evidence-based medical publications to assist with this. We help all settings of care educate patients on treatment choices and real-world expectations of true timelines to accessing new technology. We may also prepare a facility that is new to coflex for ultimate success. So really, I'm talking about full practice integration. Next slide, please. MSLs are here to service you. In other words, you have a resource for your facility and ultimately for your patients that you really didn't have before. Not many device companies to date, in fact, I can't think of one outside of Paradigm, have a dedicated MSL team. That's the difference with coflex and with Paradigm Spine. So consider us your resource. We're here to bridge the gap to accessing a one-of-a-kind spine technology. And again, I hate to sound like a broken record, but the exciting part is that this technology is applicable to any setting of care in 2017. Next slide, please. The MSL wears all hats for the company, so we act as conduits or links for our stakeholders so they can access information, people, and resources to make informed healthcare decisions for their patients. We may link up these customers with corporate research organizations. Perhaps it's insurance payer contacts or insurance assessment committees. Maybe it's key societal members. We support several spinal societal organizations and usually have a strong presence at annual conferences such as ISAS, AANS, AAOS, and Becker's. In fact, I do believe there's a Becker's conference this summer in Chicago in late June that you and I will be supporting, right, Dr. Matthews?
That's correct. Between June 22nd and June 24th of this year in Chicago, we're going to be presenting in a symposium there.
Going to be a lot of fun. Next slide, please. What can the MSL do for your practice? Well, it really starts with a coflex introduction, and that may include initial disease and appropriate patient characteristics and symptoms, to showcasing our bone model, and we might show how the device is best implanted during surgery using our model. We share our resources, including clinical articles, product information, patient pamphlets, reimbursement resources, and tons more. We really work with the total office personnel responsible for scheduling and billing to outline timelines, necessary steps, and resources that lead to coverage success. And this is important. So many corporate interactions are like a quick in, quick out, but that won't be the case with your MSL team. We truly seek to build long-term partnerships with our accounts. So we will be your partners going forward and have continual touch points in your facility's preferred mode of contact. Maybe it's phone calls, maybe you like emails, perhaps it's in-person visits. But I do promise that we'll work with you to choose the right amount of interactions that make sense for your site. Don't worry, nobody likes people to overstay their welcome, so we'll strike for that right balance with your facility. In summary, we are here to help you get up and running with coflex. And if you are already running, so to speak, then we'll help keep you on the right track. Dr. Matthews, one of the first topics we usually educate our offices on is spinal stenosis disease state management. So we'd love for you to give us an overview, including how coflex fits in.
Thanks, Devin. That was an excellent introduction to the MSL role in a medical device company. It's really a new role for medical device because most products are 510K and there's not a whole lot of evidence to talk about. And usually the discussion is features and benefits with the sales personnel. But with a new technology that has 5 levels of evidence, all documenting its presence in multiple sites of care, it's very clear that a medical personnel, a person that understands the literature and can discuss this from an MSL level, is important for your site to better understand new technology. So as a spinal surgeon, we would routinely see patients with all kinds of spinal conditions, including tumor, trauma, deformity, degenerative disease, and then more prevalently in the last 20 years has been the uptick in spinal stenosis and disease management of spinal stenosis. Next slide, please. So lumbar spinal stenosis is very prevalent in our society. It's anything that narrows the spinal canal, and it's anything that causes some neurogenic compression, either of an exiting nerve or the cauda equina or sac of nerves in the lower lumbar segment. And it can come from a combination of facet joints, lamina, loss of disc height, a bulging disc, facet cyst, or any translation that may occur at the segment, then creates a neurogenic and mechanical syndrome in the lower back. And patients will present with different symptoms of a combination of can't walk to the mailbox, but also, mechanical back pain in addition. Next slide. This is a classic presentation, and you can see it on Saturday if you go to the grocery store, people hugging the shopping cart. And it's not because they're tired and they've worked so hard that day. It's because an older person usually has to bend forward a little bit to basically open up their neuroforamen to let the exiting nerves have room to maintain neurogenic function. And so this neurogenic claudication presents, and the inability to walk distances is progressive in patients that have spinal stenosis, and sitting down relieves this. So it's a pretty easy diagnosis to make in the office, and then verified with imaging studies such as MRI or CAT scan. Next slide. And of course, if the disease progresses, the disease can cause both facet disease and early instability, for which the bones can shift forward, called a spondylolisthesis, or forward shift of the spine. This process can add additional neurogenic compression to the spinal canal and exiting nerve roots and create a progressive platform of instability that may get much more severe down the road, for which coflex wouldn't be indicated for, because that unstable patient with very loose spondylolisthesis translation is not a patient for coflex interlaminar stabilization. That will always be a fusion patient. Next slide. So conservative care is the mainstay. It's patient education, it's understanding the disease process, and it's making sure patients can modify their activities until the point that the disease takes over. And that usually presents with progressive loss of the ability to walk distances and progressive both neurogenic pain in their lower extremities and also mechanical back pain in their back. And the spine surgeon and physiatrist often try everything they can to a patient before they undergo any kind of intervention. So this failure of conservative care usually is a conclusion of, we've tried everything, doc, and nothing's making me able to function the way I want to function, and I want to be able to walk again. And walking is one of those cherished things in older years that you want to maintain the ability to ambulate. And this is something that spinal stenosis will take away from patients. So when that fails, then options become surgical. And then that's when the doctor talks about surgical options for treatment of spinal stenosis. Next slide. And there are many different ways to look at this. And, there's ways to look at the indirect and direct way to decompress things. An indirect way to decompress would be the X-stop model, or the newly approved Vertiflex model, which is an indirect distraction of the interspinous space to maybe open up the area for the foramen. Depending on the pathology and the patient's anatomy, this could provide some temporary relief. But then the surgeons are all trained on the mainstay treatment of spinal stenosis, which is direct visualized microsurgical decompression. But then the question becomes, is that enough? Or is something else needed if the facets are severely arthritic and there's problems of stability at that segment? Then some additional stabilization might be required. And as you see on the far right picture, fusion has been the classic way to stabilize a decompression with severe facet joint disease and or instability. Whereas in the middle image, that's just a simple decompression. And what happens to a simple decompression when it's unstabilized and re-stenosing effects of gravity and weight bearing can go through that segment? Next slide. And so introduce interlaminar stabilization as the middle of the bell-shaped curve that is not for the early patients that just have early disease that can be modified with conservative care. And it's not for the later patient that has severe disease with gross instability and deformity. But the majority of patients that present with spinal stenosis actually present with the disease of marked spinal canal compression, not gross instability, and up to grade 1 spondylolisthesis, and moderate to severe stenosis that's well documented with conservative care, imaging studies, and clinical treatment of the disease. So this disease continuum is early, mid, and late. Coflex really fits the mid population well, and it has evidence to prove that. Next slide. So coflex interlaminar stabilization is a load-bearing device that's inserted after a microsurgical visualized open surgical decompression. Then the surgeon sees the nerves, they see the pathology, they see the offending stenosing anatomy, and they remove that. And that's the essence of the procedure, is the decompression. The decompression is key to getting the legs feeling better so the patients can walk further. But then when you do that, you create medial facet instability, you create loss of bone and capsular stability of the facet joints, and you can create a situation that leads to vertical loss of disc height and then more re-stenosing effects down the road. Coflex then loads the laminar bone once inserted, helps to unload the facets, and actually creates a stabilizing effect on up to grade 1 spondylolisthesis. Next slide. And as you can see, Coflex loads the spine. On the left images, the lateral images show flexion and extension with Coflex in place, and so the device does bear weight. And actually, it maintains motion at the same time, helping to unload the facets and loading good laminar bone, which is important for that restabilization effect. As you can see on the right imaging studies on the CAT scan axial cut, Coflex is very close to the dura. It's 1 to 2 millimeters from the dura, and its location there is very safe and also biomechanically friendly to helping to unload the facets. Next slide. So when you think about spinal stenosis and management of such, you want to make sure that you understand that the decompression is the ultimate proof of the surgical management of spinal stenosis. And if that's done well, the patient will get better from their neurogenic disease. So coflex maintains your decompression. It acts as a safety or an insurance that your decompression will maintain its foraminal height, maintain segmental motion, and also won't do anything to the adjacent level disease. And by maintaining that foraminal height, it helps to unload the facet joints and also stabilizing the segments and up to grade 1 spondylolisthesis. Next slide. And so the indications for use are lumbar spine, L1 to L5, 1 or 2 contiguous levels, and up to grade 1 spondylolisthesis for moderate to severe spinal stenosis. Patient selection is important with any surgical procedure, and bone quality is in play with regard to older patients and the ability to stabilize with any implanted device. The IFU and SSCD and instructions for use for coflex are very straightforward and easily obtained on our website and through package information. But in general, bone quality is of importance, and also the presence of disease that you can identify, you can decompress, and you can isolate to 1 or 2 levels begins the process to see if coflex is indicated. And I would encourage you to read the indications for use. Next slide. The insertional process after decompression is very straightforward. Essentially involves a small mini open procedure, a midline approach, shaping the spinous processes to then join the lamina where a flavectomy and subflaval dissection occurs to actually remove the stenosing offending pathology. So the surgeon sees the canal, sees the nerve root, sees the foramen, and actually decompresses both foramen and actually approves that visually before considering insertion of coflex. Then in the lower right pictures, sizers are used to identify the size of coflex for neutral stabilization. As noted, this does not kyphose the spinal segment. And then for the insertion and then crimping of the wings to actually stabilize this device, loading laminar bone and unloading facet pathology. Next slide. So where's the proof? As I said earlier, Paradigm's committed to all levels of evidence for evidence-based medicine, proof of better patient outcomes for interlaminar stabilization. Fortunately, coflex has a plethora of articles written about it. And in general, you'll find that when you choose the right patient and when the technique is reproduced, coflex is very safe and effective with over 70 articles in published peer-reviewed journals. Next slide. The FDA approval process required a 5-year PMA study, which was a prospective level 1 study with a control group of decompression and fusion and the investigational group of decompression and coflex interlaminar stabilization. And this paper has been published in the ISASH journal last year. Next slide. This 5-year evidence shows a sustained VAS leg pain. So when a surgeon does decompression for spinal stenosis, you want the legs to feel better. You want the patient to be able to walk. You want them to be able to reproduce their activities of daily living going forward the way that they're used to. So the ability to prove that VAS leg pain is still good at 5 years is a good thing. And so the micro decompression of coflex for stenosis is sustainable at 5 years. And then the concomitant interlaminar stabilization helps with the back pain. And we'll show that data in a second. So this is really supportive evidence to show that the decompression is certainly adequate when coflex is implanted, and there's no shortcutting any surgical decompression techniques that need to be done for that specific patient. Next slide. And it's important too that the safety and durability of the device is important. So the decompression is important, and the foraminal height is important, and the motion is important. So if we can prove that at 5 years, we've shown that we created no downside of interlaminar stabilization. We've maintained motion, we've maintained foraminal height, and we haven't done anything to the adjacent level. So I think it's a very important attribute of this device to be able to maintain segmental biomechanics. Next slide. And as you can see here, this is not a kyphosing structure. This implant, when inserted in a neutral position on a patient placed in neutral position, actually loads, and it actually bears weight, and it actually goes through a motion arc through flexion and extension. And as you can see, it loads the U of the device with about 90% of the force going through the strongest part of the spine, which is laminar bone, and through the device, with only about 10% being spread through the spinous processes superiorly and inferiorly. So it's actually a biomechanically friendly device for lumbar loads through activities of daily living. Next slide. And as you can see here, the key part of maintaining functional biomechanics at the index level is what are you doing with range of motion at that level, and what are you doing at range of motion at above? And so we can prove at 5 years that range of motion at the operative level is still maintained. In other words, pre-op to 5 years is statistically the same. And we can also show that range of motion at the adjacent level, often a victim of static stabilization, such as with fusion, coflex does not transmit forces to the adjacent level to create hypermobility. So this is a good benefit long-term, that you're not going to create any hypermobility which could cause a stenosis and an instability pattern above a static stabilization. So this is the benefit of healthy long-term data prospectively collected. Next slide. And as you can see here, the VAS improvement in mechanical back pain is what you would hope to get with a fusion procedure. But being able to maintain motion, foraminal height, and not do anything to the adjacent level and get the benefit of facet joint relief of pain, as seen in the VAS back pain scores, are not changed at 5 years. So you've proven mechanical effect in a positive way of relieving VAS proven back pain going into the mid-8s with regard to VAS back pain down into the 2s at 5 years, suggests that this is a very durable pain relieving procedure, in addition to the decompression relief from the microsurgical decompression that the surgeon performs for the stenosis. So it's a good combination effect long term. Next slide. And with that, the ODI improvement is sustainable. So it's effective, it's durable, and it's sustainable long term. And this is really what you want to see. And if you're not going to have to fuse, you want to make sure that what you're doing is as good or better than what you're currently doing, and we can show that with long-term data from this level 1 study. So ODI is certainly sustainable and durable compared to the current standard for which surgeons are electing to do should they need this facet stabilization during the procedure. Next slide. So that's a lot of clinical information, and you heard from Devin that the role of the MSL is to help you integrate that into your front office, your mid-clinic, and then into your back office. So Devin, I'd like to transfer over to you and help us understand really how are you going to do that with the site, and also teach us some more about some of the CMS rule changes for 2017.
Perfect. Thank you so much, Dr. Matthews. That was awesome information. So you heard it from him. You're all wondering, how can your facility, how can your patients, how can everybody get on this fine coflex caboose, so to speak? So again, in recap, there's those 3 buckets that we kind of referred to earlier, which are clinical education, patient identification, and reimbursement assistance. So we're here to help your facilities and your patients access this innovative treatment. There's nothing like it on the market today. And stick around, because in a few slides, we will provide you with the direct contact information for your local MSL leaders. In short, we're bridging it all for you guys, and we're going to get into some specifics in just a moment here. Next slide, please. So again, prior to 2017, there weren't clear-cut pathways for coding or reimbursement for coflex. Some of you out there may already be familiar with this. But as of January 1st of this year, all of this changed. There is a new Category 1 code for interlaminar stabilization following a decompression surgery, all of which Dr. Matthews described. And we're going to cover that in much more detail in the next few slides. This coding clarity brings with it published Center for Medicare Services reimbursement pathways for both inpatient and now outpatient facilities. What this truly creates is an opportunity for surgeons to treat patients in the best site of service suited to their unique medical necessity. And this has never existed prior to this year. Next slide, please. The new Category 1 CPT code and the associated inpatient and outpatient reimbursement figures will be revealed officially on the next slide. Don't worry, we just want to keep you in suspense. A few considerations before the big reveal. There is a Milliman publication, which is an independent assessment of actuarial data, and that's easily provided by your MSL team. We do carry it with us in our big binders, and it shows that coflex offers significant cost savings compared to Fusion per member per month. This is information that certainly could be of interest to payers and self-funded employers. Now that the 5-year extension of the original PMA approval study has been completed and published, and the next round of post-approval studies are currently underway, we do anticipate policy coverage in the future. But no worries, in the meantime, you have your MSL team to help pave the pathway to coverage success. Next slide, please. Here it is. This is the new bundled code for coflex, 22867, which does include the decompression surgery at that level and associated image guidance. Please note more specifics in the definition associated with the code for further details. It's on the slide and you can also look it up. The second code, 22868, would be listed in addition to that primary code for a second coflex procedure performed at one additional level. So it is indicated, as Dr. Matthews referenced, for 2 contiguous levels, but no more than 2. These codes come with a published Medicare average payment for 1 and 2 level procedures at both inpatient and outpatient sites of service, and you'll see those payments on the card right there. This would include the hospital-owned surgery centers, and private or physician-owned surgery centers. Again, the surgeon now has a clear pathway to treat their patient in the site of care that's best suited to that patient's unique healthcare needs. That's the exciting part. And a clear payment pathway, which is great. This card is available through your local MSL contact, and we have it both in electronic and in hard copy forms. And again, this is national averages per Medicare, so just bear that in mind. Next slide, please. Navigating coverage to new technologies with payers can be a complex process. So I just got everybody all excited about that previous slide, but your site is really not alone in the process of gaining coverage. There's usually no prior authorization criteria for straight Medicare plans, so that's the good news, but there certainly may be for some of the Advantage plans for Medicare and of course for the private payers. So in addition to MSL support, Paradigm does partner with a dedicated team of coverage and access specialists that can assist you. They only work on the private payer side though, but they are there to assist you with private payers. Use of this service and this organization is free to you and your facility. It consists of live certified coding and coverage experts that can help you with specifics around certain payers. This service really, again, only applies to the private or commercial payers, and case managers will assist you with cases all the way from initial pre-authorization through multiple appeal steps if needed, although they can pick up at any step of the process, post-denial, etc., so long as it's pre-service, so long as the surgery has not yet been performed. That's the key. The number on the screen will connect you to the coverage and access team, but your MSLs can certainly provide you with more detailed information around this organization, who they are and what they do. Their coverage team is just one facet of the many things that this great organization is able to accomplish. Next slide, please. Your MSLs can assist with opportunities for your understanding with the pre-certification process for coflex. I referenced that before, but here's some specific resources. And these resources are ones that only your MSL team or the coverage access partners that I referenced on the previous slide with that 1888 number, only one of those 2 groups, us or them, can provide those. And those include laminated handouts, which include dictation and documentation best practices for initial submission, so the surgeon can utilize those. What to expect during the appeals process. This includes steps, timelines, etc., to help you have a talk track for patients and with payers. There's also a plethora of informational brochures for both your patients and physicians to successfully advocate for coflex following an initial negative coverage decision. So certainly these are resources that can help get the positive coverage that you're seeking. Next slide, please. There are other resources available to you within Paradigm Spine as well. Ask your MSL for more details, because I know there's a lot of information on this slide, but I'll cover it briefly. Surgeons must be trained on appropriate use of coflex before initiating a case, and they can do this by choosing between multiple training mediums. There's a 24-hour online training platform that's pretty convenient, but they certainly could request a one-on-one webinar with our education director and coordinator. They could do a live lab training. These are often held at the big societal meetings. But to find out about training and other Paradigm-sponsored programs near you, there's an events website listed above. It's the one that says www.paradigmspineevents.com. And then we did mention previously that only your MSL team can provide the reimbursement resources like the coding card, et cetera, but staff educational resources and patient pamphlets can be ordered by site. And there's a resources website for that type of staff and patient information. Your facility can create a unique user ID and password to access the site. And that's that second hyperlink, paradigmspineresources.com. So again, patient brochures, staff education, things like that, just not the reimbursement materials. We have other dedicated education and marketing partners. I have to give kudos to our director of marketing because she created this fabulous PowerPoint deck. Thanks, Janelle. Janelle Nicholson's on the line somewhere. She's probably muted. We also have an excellent surgical support team. They will come out to your facility and assist with first cases or even more complex cases, such as 2 levels, etc. Next slide, please. So here it is. How do you get in touch with your local MSL? So far, Paradigm employs a team of 17 members across the U.S., and one of these is likely assigned to your facility. Simply email one of the MSL team leads above. Erin is lead for the western portion of the U.S. You have myself, Devin, and good old middle America, all the way down to Texas, so kind of the central part. And Gay has the eastern third of the United States. We will then put you in touch with your local MSL contact. It might be us, or it might be somebody within our team. Thank you so much for your time today. I do believe that next we're going to move into a short Q&A.
Yes, thank you, Devin and Dr. Matthews, for that fantastic presentation. As Devin said, we're now going to begin today's Q&A session. Please submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We're going to try and get through as many questions as possible today. So if we're going to roll right in here, Devin or Dr. Matthews, if you could please tell us, how would you describe the new codes for coflex versus other stabilization codes?
Great. This is Hal Matthews again. The new codes for coflex are very fortunately clarifying for where stabilization has been in the past. In the past, stabilization has been linked to spinal fusion, which means that code would be in addition to an arthrodesis, and it may or may not include a decompression or laminectomy code. So now with stabilization now being recognized as its own event without having to have a fusion, this new coflex code actually creates a new code that documents a stabilization procedure. And for coflex, it's PMA approved to be done with decompression. So the code actually improves decompression with coflex interlaminar stabilization 1 level, 22867, and decompression with interlaminar stabilization 2 levels, 22868. So it clarifies the past, and it actually opens up a new category of stabilization with decompression that does not involve fusion. So it's really a pivotal point in the coding process that we've never had that ability to code for just decompression and adding stabilization without having to fuse.
Thank you for clarifying that, Dr. Matthews. In terms of payers, they often state that coflex is investigational and experimental. So in your opinion, is it worth pursuing an approval?
Yeah, I can go ahead and take that one. Thank you. So my answer would be yes, yes, and yes, based on my experience working now in this role, both last year under the old coding pathway and this year under the new pathways. So payers oftentimes lump multiple technologies together, and it's really no different with coflex. We know that there's nothing like it on the market. It's totally unique. However, it is lumped in many policies, many written policies with dissimilar devices. Lots of times the data is lumped together, the warnings and precautions are lumped together. So it really becomes incumbent upon the surgeon and facility to prove medical necessity. And that's really the only way that we're able to get approvals for a lot of these private payers. Sometimes we get approvals up front on an initial predetermination or pre-auth. Other times it happens at the peer-to-peer step, or maybe it's the second or third internal appeal. And I've seen it happen most often, usually in that appeals timeline is when we're seeing approvals. And again, there's different documents that can be submitted along the way. The MSL team can provide those documents, including talking points for surgeons, et cetera, electronic periodicals to support those conversations and different steps of submission. But it's really all about showing good medical necessity, utilizing our data. And I actually just had an example last night that my boss, Dr. Matthews, is not even aware of yet. I had a case that went to external appeal. She submitted everything, the nurse, on March 3rd and got an approval yesterday. It was the first external appeal. So it's certainly worth it. And many times coflex will get approved sooner than that. But it's nice to know that if you push the payers a little bit and show them the good data and the benefits of the patient, that we're getting approval.
Thank you so much, Devin, for kind of weighing in there. Another attendee is wondering, are peers-to-peers worthless, or do they contribute to a coverage process for patients?
Yeah, I can handle that, having done many peer-to-peers in the past. I think it's a great opportunity to look at the bigger picture, but so often peer-to-peers are done in the middle of clinic when everyone's frustrated and the surgeon's in between patients and is thinking about 1,000 things, and then all of a sudden a pediatrician gets on the line. And then you're in a process that isn't necessarily going to be clinically relevant to what you're talking about, but let's understand that those people are there for their reasons. I mean, they're docs, and we should treat them with respect. But in reality, the conversation often doesn't get clinical enough so that that person understands what the patient really needs. So I would suggest that peer-to-peers be more civil and that we understand that this is a process with the payer, that we have seen many cases with coflex where the peer-to-peer physician from the payer actually doesn't know about the technology. And when the surgeon describes that they're going to decompress and stabilize and not have to fuse, we've seen peer-to-peers flip right then, just because that was an important criteria that the clinician on the other end of the phone from the payer did not want to hear about a fusion. So I would suggest that peer-to-peers are the beginning of a process of developing a relationship with your payer, and then the ability to if you need to get a specialty-specific peer-to-peer, you can request that. But this all boils back to the expectations of the patient and the clinical process, that this may take a couple of weeks. The old days, you could get all this done in a couple of days. Now it's a couple of weeks, and that's the same for fusion too. So you're doing peer-to-peers with fusion, and you're still doing them with coflex, and we'd certainly like to change that soon. But for now, peer-to-peers are the beginning of the process, which may lead to an appeal, and appeals do flip every day. So this is the process that we can help payers understand the uniqueness of this technology and actually get this opportunity for patients all over the country.
Thank you so much, Dr. Matthews, for clarifying that. This question is related to patients. So what if my patient doesn't want or is unable to wait for a coflex approval?
Yes, I can take that one as well, because I do have a lot of experience with this in offices. I definitely think that the first thing that needs to be done is a level set, that initial conversation with a patient. We know that most of, if not all of, the private payers don't have coverage policy yet written for coflex. So letting patients know that up front, that the surgeon has chosen this technology, that he believes that the decompression alone won't be enough for the patient, but that fusion would be overkill, and kind of getting that patient bought into the why behind he wants to utilize this technology for them is key. And then the next statement should be something along the lines of, we're not sure how long it's going to take for your insurance to cover it, and making sure the patient is able and willing to wait for the surgery and wait for the approval that may take a couple steps. Certainly it could take, as little as a month, it could take 3 months, it could take less than that, it could take more than that. It's really hard to say. I've seen the gambit. So just making sure that patients are able to mitigate their symptoms in the meantime. But most patients that are given the choice, where fusion would be over treatment, don't want to be fused for good reason. And coflex seems to fit kind of that middle spectrum for those types of patients, and they really want the technology, and many of them are willing to wait. But if the conversation is not brought up and expectations aren't set in the beginning, then everybody's kind of frustrated as they're waiting. So it's just a matter of, we recognize that some patients are in pain and some can't mitigate their symptoms, but I think it's all in how it's set up in the beginning with the patient. And that's part of what we do, the MSL team, is coach and educate on having those conversations with patients and provide resources to have those conversations.
Thanks so much, Devin. It totally makes sense. We have time for one more question here. So what is Paradigm Spine doing to educate insurers to get better coverage policies for coflex?
I can take that one for sure. That's certainly a frustrating process from our end. Payers have their own rules. There's no national standard for what payers use for their guidance for coverage policies. And within each individual national payer, there are different rules for each. So you not only have different medical directors, different chief medical officers, different rules of engagement, but also different standards for which they will cover something and not. So that leads to a black box of the unknown with regard to us being able to engage the payers and get to the bottom of what the issues are. Interestingly, we found out that there's such a toxic environment for fusion. And anything that involves stabilization, as I mentioned earlier, is equated with fusion, because that's the way that it's always been linked together. And so if you're in the box that you're another device that may have to deal with stabilization, then it's assumed that it's a fusion device, and it's assumed that there's war on fusion, and it's assumed that there's going to be a very difficult conversation with the payer. And part of our job has been to use all the levels of evidence that we have, all of our level 1s, 2s, and 3 studies, to show payers that this is not a fusion device, that by the FDA standards and by its conditions of use has nothing to do with fusion, and that it is sustainable and durable long-term at 5 years in published evidence. And the fact that this is something that offers an alternative to not having to fuse first. Not saying fusion is not important to spine surgeons to treat patients, but it's not necessarily the only option that you can use for stabilization. So this educational process has been a national effort with multiple payers at different levels, and it evolves monthly. Literally, we are faced with different situations and different conversations with payers monthly, but we're certainly engaged. We're certainly advocating for patients and physicians to have access to the technology for the right indications, and we're certainly using evidence, both our retrospective studies, which we're collecting in many states throughout the country, and also our prospective studies, including our coflex community study, which is a prospective observational study of patients' data collected in community use of coflex in non-PMA sites. All that information payers love to see. So eventually this will become a national covered product, but at this stage we're still working on a day-to-day basis with each payer. But that doesn't mean that they're not going to cover the surgery. It just means that they don't have a written policy. So we're at the stage now where we're getting a lot of coverage, but we want the stage where we get written coverage decisions, so it's etched in stone and it's going to be there permanently. And that's what we're striving for every day.
Thank you, Dr. Matthews. And that is all the time that we have for today. I want to thank Dr. Matthews and Devin for their excellent presentation, and to our audience for your participation today. Please enjoy the rest of your day, and we look forward to having you join us for future webinars.